Let's learn about diabetes mellitus, its definition, signs and symptoms, types, and pathophysiology in a simple and easy way. Insulin. It is the main hormone that controls metabolism and lowers blood glucose levels. When insulin is reduced, absent, or the body becomes resistant to it, especially in obesity, blood sugar rises, leading to diabetes mellitus. Diabetes mellitus. It is a chronic metabolic disorder characterized by high blood glucose levels, called hyperglycemia. It is diagnosed when fasting plasma glucose is more than 7.0 millimoles per liter, or when plasma glucose is above 11.1 millimoles per liter 2 hours after a meal. It occurs due to insulin deficiency, often combined with insulin resistance. As a result, the liver releases excess glucose, and skeletal muscles cannot properly take up glucose or store it as glycogen, leading to persistent high blood sugar levels. In diabetes, various complications develop as a result of long-term metabolic disturbances, often over many years. Many of these complications are due to damage to blood vessels. This damage can affect large blood vessels, called macrovascular disease, or small blood vessels, known as microangiopathy. Macrovascular disease involves accelerated formation of atheroma, leading to narrowing of arteries and increased risk of thrombotic complications. As a result, people with diabetes are more prone to heart attacks, strokes, and peripheral vascular disease, and these conditions are often more severe than in non-diabetic individuals. Microangiopathy, on the other hand, is a distinctive feature of diabetes. It mainly affects small blood vessels in the retina, kidneys, and peripheral nerves, leading to complications such as retinopathy, nephropathy, and neuropathy. Diabetic ketoacidosis is a serious acute emergency caused by severe insulin deficiency. Without insulin, the body cannot use glucose for energy and rapidly breaks down fat, producing large amounts of acetyl-CoA. In the absence of normal carbohydrate metabolism, acetyl-CoA is converted into ketone bodies such as acetoacetate and beta-hydroxybutyrate, which cause metabolic acidosis, making diabetic ketoacidosis a life-threatening condition requiring urgent treatment. Diabetic neuropathy occurs due to the accumulation of osmotically active glucose metabolites formed by the enzyme aldose reductase. However, drugs that inhibit aldose reductase have shown limited success in treatment. There are two main types of diabetes mellitus. Type 1 diabetes mellitus. It was previously known as insulin-dependent diabetes mellitus, or juvenile-onset diabetes. It usually occurs in children or adolescents, and patients are often not obese at the time symptoms first appear. Type 1 diabetes is caused by an absolute deficiency of insulin due to autoimmune destruction of the pancreatic beta cells. As a result, the body cannot produce insulin. Without insulin treatment, these patients can develop diabetic ketoacidosis, a life-threatening condition, and may ultimately die if not treated promptly. Studies of identical twins show that even genetically predisposed individuals often need an environmental trigger to develop type 1 diabetes. One such trigger may be a viral infection, such as Coxsackie virus or echovirus. These viruses can damage pancreatic beta cells and expose antigens, which then initiate a self-perpetuating autoimmune response. A person becomes clinically diabetic only after more than 90% of the beta cells have been destroyed. This long pre-diabetic phase offers hope for early intervention. Strategies like immunosuppression, early insulin therapy, antioxidants, and nicotinamide have been explored, but so far results have been disappointing. However, research in this field remains very active. Type 2 diabetes mellitus was previously known as non-insulin-dependent diabetes mellitus, or maturity-onset diabetes. It is characterized by both insulin resistance, which often develops before the disease becomes obvious, and impaired insulin secretion. Both of these factors play a major role in its development. Patients are commonly obese and usually present in adulthood. The incidence increases progressively with age, as pancreatic beta cell function gradually declines over time. Now let's understand the pathophysiology of the diabetic state. Normal glucose regulation is a complex process that involves several important factors. These include insulin, counter-regulatory hormones such as glucagon, incretin hormones released from the gut, and amylin. All of these work together to maintain blood glucose within a normal range. If there is any imbalance or dysfunction in these factors, whether reduced insulin action, excess counter-regulatory hormones, or impaired incretin effect, blood glucose levels rise, leading to the development of diabetes. Insulin plays a vital role in regulating the metabolism of carbohydrates, proteins, and fats. First, it promotes the uptake of glucose from the bloodstream into the body's cells, helping to lower blood sugar levels. Second, it stimulates the conversion of glucose into energy storage forms such as glycogen and fat in the liver, muscles, and adipose tissue. Insulin also facilitates the uptake of amino acids into cells and supports their incorporation into proteins, promoting growth and repair. At the same time, it inhibits the production of new glucose from the liver and reduces the breakdown of stored glycogen and amino acids. Finally, insulin decreases the breakdown of fatty acids into ketone bodies, preventing excessive ketone formation. Let's understand counter-regulatory hormones in more detail. Counter-regulatory hormones are hormones that oppose the action of insulin. While insulin lowers blood glucose by promoting its uptake into cells, these hormones increase blood glucose levels, especially during fasting, stress, illness, or hypoglycemia. The main counter-regulatory hormone is glucagon, which stimulates the liver to release stored glucose and produce new glucose. Growth hormone reduces the effectiveness of insulin and decreases glucose uptake by tissues. Catecholamines, such as epinephrine and norepinephrine, are released during stress and increase blood glucose by stimulating glycogen breakdown. Cortisol promotes glucose production from non-carbohydrate sources and contributes to insulin resistance. In diabetes, excessive action of these counter-regulatory hormones, combined with inadequate insulin action, leads to persistent hyperglycemia. When glucose is taken orally, it stimulates a much faster insulin release compared to intravenous glucose. This is known as the incretin effect. The reason is that incretin hormones, gastric inhibitory peptide, or GIP, and glucagon-like peptide 1, or GLP-1, are released from the intestines in response to food intake, even before glucose is fully absorbed into the bloodstream. These hormones enhance insulin secretion from the pancreas after meals. However, in diabetes mellitus, the postprandial secretion of GLP-1 is reduced, while GIP levels are normal or even increased. GLP-1 plays several important roles, including stimulating insulin release, suppressing glucagon secretion, slowing gastric emptying, and promoting a feeling of fullness after meals. Let's look at the important actions of GLP-1. First, it increases glucose-dependent insulin secretion, meaning it stimulates insulin release only when blood glucose levels are elevated. Second, it inhibits inappropriate glucagon secretion, preventing excess glucose production by the liver. It also promotes cell growth and replication, supporting pancreatic beta cell function. In addition, GLP-1 slows gastric emptying, which helps control the rise in blood sugar after meals. Finally, it suppresses appetite, contributing to better weight and glucose management. Amylin. It is a hormone that is co-secreted along with insulin from the pancreatic beta cells. It works together with insulin to help regulate blood glucose levels, especially after meals. In individuals with type 1 diabetes mellitus, there is little to no insulin production, and therefore little to no amylin is produced. In type 2 diabetes mellitus, amylin is produced, but usually in insufficient amounts, contributing to poor glucose control. Amylin helps lower postprandial, or after-meal, blood glucose levels through several important actions. First, it prolongs gastric emptying time, which slows the rate at which food leaves the stomach. This helps prevent a rapid rise in blood sugar after eating. Second, it decreases postprandial glucagon secretion, reducing excess glucose production by the liver. Finally, amylin suppresses appetite, promoting a feeling of fullness and helping regulate food intake. Together, these actions support better control of blood glucose levels after meals. Now let's understand the development of diabetes. First, type 1 diabetes develops due to a combination of genetic predisposition, environmental triggers, and autoimmune processes. Type 1 diabetes mellitus is the result of immune-mediated destruction of the pancreatic beta cells. It is typically characterized by an abrupt onset of clinical signs and symptoms, such as excessive thirst, frequent urination, and weight loss. Genetics. It plays an important role in its development. However, studies of identical twins show about a 50% discordance rate, meaning that not both twins always develop the disease. This suggests that environmental factors also contribute. Possible triggers include infectious agents, certain chemicals, and dietary factors, which may initiate or accelerate the autoimmune destruction of beta cells. Now let's look at the environmental and autoimmune factors involved in the development of type 1 diabetes mellitus. Environmental triggers are believed to play an important role. Viral infections such as rubella and Coxsackie B virus have been strongly suspected. In addition, certain chemical exposures and even dietary factors, such as early exposure to cow's milk, have been proposed as possible contributors. These environmental factors may act as triggers in genetically susceptible individuals. Autoimmunity. It is a key component in type 1 diabetes. An abnormal immune response, possibly initiated by these environmental triggers, leads the body to mistakenly attack and destroy its own pancreatic beta cells. In type 1 diabetes mellitus, an autoimmune process destroys the pancreatic beta cells. At the time of diagnosis, most individuals have detectable anti-insulin or anti-islet cell antibodies in their blood. These antibodies indicate that the immune system is attacking the body's own insulin-producing cells. One of the most important antibodies is directed against glutamic acid decarboxylase, commonly known as GAD. Antibodies to GAD are found in approximately 70% of individuals diagnosed with type 1 diabetes. The presence of these antibodies can serve as an immunological marker and may help predict the future development of the disease in at-risk individuals. Now let's discuss the development of type 2 diabetes mellitus. Type 2 diabetes is associated with genetic factors, beta cell dysfunction, and defects at peripheral sites such as muscle and liver tissues. Genetics. It plays a major role in its development. Studies show that identical twins have more than a 90% concordance rate if one twin has type 2 diabetes. This strongly suggests that the disease is predominantly influenced by genetic factors. In addition, if a parent has type 2 diabetes, the risk of the offspring developing the condition is at least 15%, highlighting the strong hereditary component of the disease. In type 2 diabetes mellitus, beta cell dysfunction plays a major role in disease development. At the time of diagnosis, typically only about 50% of the pancreatic beta cells are functioning properly. As the disease progresses, the number of functioning beta cells continues to decline, leading to worsening insulin deficiency over time. Peripheral site defects. It also contribute to the development of type 2 diabetes. These may include problems in insulin receptor function or a decreased number of insulin receptors on target tissues. As a result, even when insulin is present, the body's cells do not respond effectively, leading to persistent hyperglycemia. Secondary diabetes occurs when high blood glucose develops as a result of another medical condition or due to certain medications. It can be seen in endocrine disorders such as Cushing's syndrome, where excess cortisol increases blood glucose levels. Acromegaly, where excess growth hormone causes insulin resistance. It may also occur in genetic or chronic conditions like cystic fibrosis and Down syndrome. Pancreatic disorders, including inflammation or damage to the pancreas, can reduce insulin production and lead to diabetes. In addition, certain medications such as glucocorticoids and some antipsychotic drugs can impair insulin action or increase glucose production, resulting in hyperglycemia. In secondary diabetes, managing the underlying condition or adjusting the treatment may help improve blood glucose control. Warning disclaimer. This video is for educational purposes only and is not intended to replace professional medical advice. Please consult a qualified doctor or healthcare provider for proper diagnosis and treatment. Thank you for watching. If you found this video helpful, don't forget to like, share, and subscribe for more educational videos.